My name is Jakob Stensballe. I'm a medical doctor, have a PhD in trauma, and I'm a consultant anaesthetist primarily working with trauma anesthesia. I'm part-time employed in Department of Anesthesia at the Trauma Center here in Copenhagen and part-time employed in the blood bank because I've been affiliated with the blood bank for more or less 12 years and are one of the founders together with Professor Per Johansson of the Copenhagen concept that is in general a strong collaboration between the blood bank and the clinical settings in the management of bleeding patients. Alright, thank you so much for the opportunity to give this talk on the management of bleeding patients. I will try to focus on haemostasis and transfusion therapy in the management of bleeding patients. One particular thing that is important to me is to stress that I have no conflicts of interest in relation to this talk or anything else. In patients bleeding, we know that coagulopathy is an important part, and coagulopathy actually increases mortality both in patients undergoing major surgery and especially in trauma. Exsanguination as a part of trauma is still a very important part of the mortality. Up to 1/3 of patients die from coagulopathy and exsanguination. So it is an important problem. The main part of the treatment is to stop the bleeding. This is extremely important that surgeons should be part of the treatment, surgeons should be in there and stop the bleeding as early as possible. Every drop of blood is important for keeping the haemostasis of the patient. So the primary part is to stop the bleeding, and while doing so we will then manage haemostasis, try to keep the patient alive. This picture is to show you the normal hemostasis clot build up on a burned patient where you can see the normal clotting, just signifying the importance of treating the patient from a clinical point of view, looking at the patient, seeing if the coagulation, the clotting is working normal as seen here, or if it's abnormal and actually has developed as a coagulopathy, that is an oozing bleeding without any signs of clotting. This can be seen here. This is actually blood on the floor from a trauma resuscitation. You can see that there's absolutely no clotting on the floor, signifying that this patient is severely coagulopathic. And the important part is that the mortality of this patient is extremely high, maybe 70 to 80%. And the important part is also that how would you in any way expect the surgeon to get control of bleeding if there's no clotting at all, and especially if there's no blood clotting on the floor, then it's impossible to expect the surgeon to get control of bleeding. So avoiding coagulopathy is extremely important. We need to be aware of the developed coagulopathy as seen on the right, and how to manage to get the patient back as seen as the left side, where you can see there's actually clotting on the floor here. Big clots signifying that the hemostasis is working in a normal fashion. But it's actually not that difficult to understand hemostasis. This is a little bit chaotic slide of the hemostatic system, just to show that it's a big and very complex system. The important part is to understand it's a very well adjusted system, even though complex. So it can actually adjust for deficiencies in one part of the system. It will adjust by increasing or decreasing activations or deactivations in another part of the system. So it's a big complex system. The important part is to know that it's very well adjusted. What we are most interested in is actually this. This is the clot in life. This is actually the collaboration between red blood cells, as seen red here, together with the fibrin strings, as seen green here, and collaborating with the activated platelets, as seen blue here. So this is actually a clot in vivo, in the system, just lining up to the endothelia. So you can actually see the formation of a normal clot in the system here. And this is extremely important that you have a patient bleeding. You need to make sure that the clotting is normal throughout the phase of the bleeding. When the bleeding is under control, then it's not that important anymore. But during the phase of bleeding, we should have a goal of keeping the patient's hemostasis, the clotting, completely normal. The blood is three main parts. You have the red blood cells, the erythrocytes, is approximately one half of it, and then you have plasma that is a little bit more than a half. The red blood cells actually work with the transportation of oxygen to secure that you have cellular and systemic oxygenation. The plasma phase is actually nutrition, and in relation to this talk, plasma proteins that actually works in the coagulation cascade. Together with this, they actually collaborate very closely with the platelets. You can see them here in the buffy coat part of the picture. So you have three phases in whole blood that actually collaborate very closely together. The plasma, the proteins, the platelets, and the erythrocytes, all collaborating very, very closely to make sure that you have a normal clotting capability. This is the system of the vascular bed. This is actually seen here from the side of the intravascular lumen. On the top you see the endothelial part, you see the basal membrane, you see the endothelial cells, and then you have the surface of the endothelium, what we entitle the glycocalyx. That is actually a slippery surface to avoid activation of the clotting where there's no lesions. So this is how it's built up in real life. And in the systemic part of this, in the intravascular bed, you have the erythrocytes, the red blood cells, circulating with a few white blood cells seen here. You have another component that is the platelets. They are very close to the endothelium. And a third part, as mentioned in the slide before, is the coagulation factors, the plasma phase, that actually can interact. So in normal life it actually looks like this. This is normal hemostasis, not activated, but with the three main components, red blood cells, proteins, and platelets, working together, avoiding too much activating and avoiding any bleeding if there is a sign of injury. If you have a site of injury, as seen on top here, you can see that actually a surgeon has done an incision, you have a lesion here, you will then have an activation to stop the bleeding. The activation is by tissue factor that activates the system, and you have the first small thrombin generation. The first small thrombin generation is important because it's only a small part, and the purpose of that thrombin generation is to activate the platelets from an inactive form to an activated platelets, and then on the surface of the platelets you have all the funny things going on. You have the thrombin bursts, and the thrombin burst is a cascade of thrombin, and the purpose of that is to cleave fibrinogen to fibrin, and the fibrin is actually the strings, the green strings seen on the photo in the beginning, but here they are orange. But the fibrin strings are actually the clot. They are actually with activated platelets inserted together, collaborating closely with the fibrin strings to form the clot. So the fibrin strings are extremely important to make sure that you have a clot that can stop the blood from going out of the vascular bed. So looking at the cell-based model of coagulation, you can see that there's an activation phase leading to the first thrombin generation. Then you activate platelets and you get a thrombin burst, and depending on the size of that thrombin burst, you will cleave a lot of fibrinogen to fibrin and get the fibrin mesh work with activated platelets. That is what we entitle the clot, the normal clotting capability. So this is actually a very simple way to understand hemostasis. The two important parts are the first, activation. The second part is on top of the platelets you have the thrombin burst, and that's the main part that you need to understand when you're working with coagulation. Management of bleeding patients can generally be divided into three groups. You have a group of patients not bleeding, you have a patient with moderate bleeding, and then a patient with massive life-threatening bleeding. The patients with no bleeding, we will not go into this treatment much further here, more than just saying that in that group of patients you should be generally very restrictive with transfusion therapy in those patients. patients with moderate bleeding are generally patients where you treat them according to the normal practice. You work with them, you stop the bleeding, you perform the surgery needed, and then you use the blood products needed to treat the moderate controllable bleeding. The patients with massive bleeding is generally a condition where you have massive life-threatening bleeding. The patients are with in a picture of circulatory failure, needing a lot of transfusions right away, needing a surgeon in there to stop the bleeding, otherwise they won't survive. So this is a life-threatening condition, massive hemorrhage, and this is a condition where you should be very liberal, very aggressive with the use of blood products, very aggressive with the surgical intervention to stop the bleeding, get control of the situation, and then you continue the treatment according to the moderate controllable paradigm. Treatment of massive bleeding is generally advocated as a treatment of what the patient is actually losing. The patients are losing whole blood. They lose red blood cells, plasma and platelets in a balance, and you should actually substitute what they are losing. So you should substitute red blood cell, plasma and platelets in the same balance as they are losing. Generally, this is conceived as the ratio 1:1:1. That is 1 RBC, 1 plasma, and 1 platelets, each of these three from one donor, single donor products. Give them this in a balance until you get control of bleeding, and then you can stop the transfusions. This is in the international literature mentioned as the ratio 1:1:1 concept, and this is what we entitle hemostatic resuscitation or damage control resuscitation in trauma literature. In Scandinavia we have blood products, RBCs, plasmas are generally the same as in the international countries like UK or the USA, but platelets are pooled. They are concentrates from 4 donors as compared to the American or the UK platelets. They are from single donors. So the Danish or the Scandinavian platelets are concentrates pooled from 4 donors, and that is why that in the international literature this concept is entitled 1:1:1, but in Scandinavia this is entitled 3:3:1 or 4:4:1, depending on the size of the pooled platelets. But more or less this is the same. This is a balanced transfusion therapy, hemostatic resuscitation, giving the patient what they're actually losing, a balance of red blood cell, plasma and platelets according to what they are losing. The concept is to give them in the same speed as they are losing it. Try to resuscitate them according to the blood pressure or the pulse or whatever you're using to keep them alive long enough for the surgeon to get control of bleeding. While you do this, you should warm the blood. You should make sure that the other parts of resuscitation is normal, and then you should actually continue this strategy until control of bleeding. In 2004, here in Copenhagen, we implemented a concept called the Copenhagen concept. This is the package solution. Back in 2004, we implemented the use of these transfusion packages. You see them on the right. That is 5 RBCs, 5 plasma, and 2 platelet concentrate pooled from 8 donors. This is actually signifying a ratio 1:1:1, and we used that back in 2004 at the same time as other groups, John Holcomb's group in Iraq and Afghanistan, at the same time implemented use of the transfusion packages and the ratios at that time. But the concept of the transfusion packages, even it's Danish or the international version, is to substitute what the patient are losing and give them a balance of blood products very equal to whole blood, as long as they're challenged by a life-threatening or massive hemorrhage. When you get control bleeding, then you stop the transfusions. Several groups have looked at the importance of the dosage of the plasma. On the right you see Borgmann's paper showing the military setting that if you gave a high dosage of plasma to RBCs, that is equal 1:1, you get the highest survival of the patient. This was also seen in civilian patients, especially Dr. Mark Merkeley of Germany in 2007 showed that this was also the same for civilian trauma. Professor Johansson and I showed it in 2009 that we saw the same in a mixed population in trauma and non-trauma, that going for the high ratios of plasma to RBC, that is more or less 1:1, signifies the highest survival of our patients. Platelets are also extremely important. On the right you actually see my platelets activated. On the surface you see the clot buildup, you see the fibrin strings. You can actually advocate that platelets are extremely crucial and pivotal for hemostasis, because it's actually on the surface of the platelets that all the funny things is actually activated. So platelets are important for a normal hemostatic buildup, and that is what we've seen in this paper. This is a descriptive study from Professor Holcomb of Houston, approximately 700 trauma patients arriving, and depending on the dosage of plasma and platelets, you could actually see by giving a moderate dose of plasma and platelets, especially plasma, that is 1 to 2, more or less, of plasma to RBCs, you can see an improved survival. But going to the highest dosing of plasma and platelets, that is 1 to 1 or equal, you actually get the best protecting effect on mortality, that is actually a hazard ratio that is reduced. So you have a 60 to 70% reduced risk of dying by giving the highest dosages of plasma and platelets. This is a descriptive study. This is a prospective study. There was some of the best we had at that time, but actually now we have a randomized control trial. We have this very important landmark study by Professor Holcomb of Houston, randomized control trial performed in 12 centers in the United States, looking at trauma patients with massive hemorrhage arriving to the center and then randomized to either receiving a 1-to-1 strategy of plasma, platelets and RBCs, or a 1 to 2 strategy of plasma. So this study were randomized, showing that from the earliest phase you could actually randomize patients to either 1-to-1 or 1 to 2 strategy. The important part of the study was that design was fantastic, and they were actually able to get the intervention started within 8 minutes of arrival, showing that they actually could aggressively early implement a strategy for resuscitation. Depending on the randomization, the patient either then received within 8 minutes a 1-to-1 strategy or 1 to 2 strategy. So this intervention, this randomized study, tested really the early intervention using either a 1-to-1 or 1 to 2 strategy. The results of the trial was that the mortality at 6 hours were reduced. The number of patients dying related to exsanguination were significantly reduced. And you can see here by the Kaplan-Meier curve, that is survival curves, that in the red box on the left you can see that the survival curves actually divided already within the first hour. So this is related to the very early intervention, the 8 minutes intervention of the patients either receiving 1 to 2 or 1 to 1. By using this very early intervention at the high dosing 1 to 1 as compared to 1 to 2, you could actually improve survival, and that divided the curves already within the first hour. You can see the curve dividing throughout the phase, and you can see that they are separate at 24 hours at 30 days. But unfortunately this trial was a little bit underpowered, and it was not able to show more than a tendency towards a better 24 hours mortality and a tendency towards a 30-day mortality. Had they had a larger trial, they had probably could be able to see a statistically significant improvement in survival of patients receiving 1-to-1 as compared to 1 to 2. So from an international perspective, this study just showed us that this is the way to go. This is trauma patients, but this actually goes as well for other patients. So the recommendation now in Denmark, in Scandinavia, in the United States and in the United Kingdom is that you actually resuscitate patients with massive bleeding with a ratio aiming at a 1:1:1 strategy. That is in the UK and the US. In Scandinavia, you would work with a ratio of 4:4:1 or 3:3:1, depending on the platelet concentrate size. But the strategy is to give what the patients are losing, give them 1:1, give them a whole blood resuscitation during the phase of massive bleeding. So going back to getting control of bleeding, you can actually have the control of the massive bleeding, get a more moderate bleeding, and then you shift from a strategy being very liberal, giving a high dose of plasma and platelets, to a strategy where you actually give the patients what they are lacking. But how do we know what the problems in the hemostasis are? How do we know if it continues to be a surgical problem causing the bleeding, or it's actually a coagulopathy? Coagulopathy is a disturbance in clotting, giving us this oozing, this lack of a clot build-up forming at the patient's surface. That can be caused by many medical factors. That is anemia, that is consumption of coagulation factors, that is hypothermia, acidosis, that could be fibrinolysis. So there's a lot of causes for this coagulopathy, and this is a little bit difficult to know which of these are the problem, especially knowing what to do then, how to treat it. And this is going back to just hemostasis, understanding that this is a very complex system, this is very well adjusted, and you can actually, by knowing that it's a well adjusted system, remembering that even though that you have a small change in the INR, for example, it increased a little bit, or an increase in the PT, you can actually only see a small fragment of the system, not knowing how the rest of the system is actually compensating. So this is just for reminding that the hemostatic system, the hemostasis, is a very well-adjusted system that adjusts for deficiencies in the other parts of the system. So if you work with this model of hemostasis, you need to actually look at what the goal of the hemostasis, that is normal clotting, and you need to monitor the normal clotting. For many years we have had the understanding of the cascade model of coagulation, that is the PT, the INR, the APTT measurements developed to adjust anticoagulation therapy, but for many years we have not had anything else to work with in transfusion medicine, and that's why we've been using these assays to understand if there was a lack of coagulation factors, or if the platelet count was low. Even this do not reflect functionality, if the platelets work or not, and this is one of the things that we've had these assays for many years, but we have no data supporting that there's a correlation between INR, PT or APT in the relation to bleeding, and especially there's no data supporting that these assays can be used in transfusion medicine to improve patient outcome. So we have been using these assays for many years related to the lack of beta, and currently we do have beta. So actually, in my point of view, this is of no use when you're talking bleeding patients, especially when you're talking about management of bleeding patients from a transfusion medicine perspective. We need to understand what we're actually monitoring with these assays. If you look at the INR, the PT or the APT, you actually only look what is going on in the plasma phase of the clotting. That is the yellow part, looking at how some of the enzymes, not all, but some of the enzymes is actually working, and you have no idea what is going on in the platelet part or in the RBC part of hemostasis. So only working with APT on INR, you actually only look at small fragments of hemostasis. We need to look at this as shown before. This is a normal clot, showing the collaboration, the close collaboration between fibrin strings, erythrocytes and platelets, making the normal hemostatic plug, stopping the bleeding, and this is what we should monitor. In order to monitor the the clots, you have two technologies on the market currently. These are entitled the viscoelastic hemostatic assays, the thromboelastograph, the TEC, and the thromboelastometry, the ROTEM. Two technologies that in my opinion are completely the same. They monitor the same, and the evidence to supporting them is more or less the same. So in my view, you can use these two analyses interchangeably. In Copenhagen we work with the TEC. We've done that since 2004. But I will try to explain the concept behind these viscoelastic hemostatic assays. As compared to the standard plasma assays like the APT, the INR, this is whole blood analysis. They work with whole blood. They monitor how clotting is in whole blood as compared to only looking at the plasma phase. And they actually measure the physical, the viscoelastic probability of the clot, looking at the clot formation, the propagation, the strength, and especially if there's a degradation that is abnormal. And this can be done very rapidly. Already within 10-15 minutes you can actually have an analysis that actually signifies if the clotting is normal or if it's not normal. Not normal signifying that there is a coagulopathy, and you actually have found the cause of the coagulopathy in order to treat this, so the patient can get from coagulopathy back to normal clotting capability. The concept is seen on the left, and then the right on the bottom. That is the traces. The left is the TEC trace and the right is the ROTEM trace. It signifies the same. You have first a coagulation activation, that is the R time in the TEC, looking at the first phase until activation of the first fibrin strings, measuring that part. Then you have a trace showing that the broader the better, according to the strength of the clotting. In the TEC it's called the MA, is the maximum amplitude, is measuring the strength of the clot. In the ROTEM it's called the MCF, the maximum clot firmness. It's more or less the same, and you can actually monitor this. The concept of the analysis is that you have a cup, you put in blood, you have a pin in the cup, and then you get a rotation between the pin and the cup. And when you have the first fibrin strings formed in between the pin and the cup, that you have detection of movements, and you can actually see that by measuring that. Now you have a formation of the R time in the TEC or the CT time in the ROTEM. Then this cup and pin continues to rotate, and you can have a measurement of the clot strength, that is the MA, the maximum amplitude in the TEC. So this is the concept of the viscoelastic assays, that you see an activation time and you measure the clotting strength according to the amplitude of the trace. When you talk about bleeding patients, the broader the better of the trace, because this is signifying that you have a good strength of the clotting, and this is better when you need to stop the bleeding. After the maximum clot strength, you can actually continue to measure if there's any kind of degradation that is increased, that is an increased fibrolysis, and that is seen both in the TEC and the ROTEM as a percentage of lysing. But the important part is that the TEC and ROTEM are working in whole blood. They are working in real time. Within 15 minutes you have a results of your analysis, and this enables you to understand if you have a patient with a normal clotting or you have a patient with coagulopathy, in order to treat the coagulopathy. All patients will have one of these traces. This is the TEC traces. You could also show the ROTEM, but we will continue in this lecture with the TEC traces. You either have a normal trace and see it on the top part. If TEC is normal, you have normal clotting, and then you have a surgical bleed. The hole is too big and the clotting cannot stop the bleeding, so you need to continue to treat the surgical cause of the bleeding. The other 6 traces are different types of coagulopathic traces, showing us that there's some kind of coagulopathy that can actually be treated in order to reduce the coagulopathy and assist in the control of bleeding. On the left upper side you have the hypercoagulable trace, showing that there's a lack of coagulation factors plasma because there is a prolonged time to activation. The R time is prolonged. In the middle on the left side you see the hypercoagulable profile with a low maximum amplitude, showing that you have a low clot strength. That signifies more or less that you have a lack of platelet function. You have either thrombocytopenia or you have a dysfunction of your platelets. On the left bottom trace you see the primary fibrolysis, that is the increased fibrolysis. You see that the trace is actually activated. You have a good clot strength, but the trace is actually degraded very rapidly. The fibrolysis is abnormal, increased, and you call this condition hyperfibrolysis. And this is a condition that is correlated with a very bad outcome. Actually, in trauma, patients in major surgery have an increased mortality. In trauma, it's approximately 70 to 80% if you have developed a coagulopathy like this. The treatment of this increased fibrolysis is, of course, tranexamic acid and continue the search to control the surgical bleeding. On the right side, you have three different profiles, either a very active way, a late fibrolysis, and on the bottom right you see a typical profile where you both lack coagulation factors and platelets. That is a prolonged R time, the prolonged time to activation. I have also a very low clot strength, and this patient is severely coagulopathic, needing treatment to get back to normal hemostatic capability. So again, this is a normal profile. You see the dotted line is a normal patient. The black trace is a patient trace. And you see that actually in the tech you can have this graphical view where you can see that the patient trace, that is the black one, is actually following the dotted purple line. So this signifies that already within 10 minutes you can see that the patient is actually clotting normally, and after 15 minutes the trace is done and you can conclude that the tech is normal, that the hemostatic capability according to the tech is completely normal, and you actually need to continue the search for the surgical cause of bleeding. On the bottom part of the traces you have the different variables. When working with bleeding patients you need to focus on the R time and the MA, that is MA is the strength of the clotting, to see if the strength is decreased. For a couple of years the focus on fibrinogen has been large. There's a lot of interest in fibrinogen substitution, and this is related to some of the early studies by Dr. Hippala of Finland in 1995, showing us that fibrinogen is the first factor that is actually reduced, and this is maybe important for bleeding patients to substitute this if there's a low level, because if there's no fibrinogen you have no ability to cleave fibrinogen and get the fibrin strings forming the clot. So from that point of view, fibrinogen is important, and this can be treated in bleeding patients with use of fibrinogen concentrate or cryo. But the most important part is that we need to then be able to rapidly measure this, and this is a little bit difficult in standard fibrinogen assays. In our center it takes 1 hour or 1 hour and a half, maybe 2 hours to get a fibrinogen result. But in the tech and the ROTEM you can actually get a rapid result on the fibrinogen. The concept is that you actually can inhibit, as seen on the right, the platelets by using a drug to avoid the interaction between the platelets and the fibrinogen, and then by this forming only a fibrin clot without the activation of platelets. This is seen here both in the tech and the ROTEM. On top you have the tech traces, the functional fibrinogen on the top, showing us that the green trace is actually the MA, the maximum amplitude of the functional fibrinogen. Normally it's in between 14 and 25, and this patient has a level of 6.3, and that is actually severely decreased, signifying that this patient has a reduced global clotting strength, and the reason for that is a lack of fibrinogen. So if the patient on top actually were bleeding, this was a patient where you can consider substituting either cryo or fibrinogen concentrate to normalize hemostasis. The Rotem trace on the bottom actually shows the same thing. But all these TEC and Rotem machines needs algorithms to work with. And this is an example of the Danish algorithms, either for the TEC or the Rotem, just to show how you can work with them. You see on the left column you have the TEC, the right, the number 2 from the left is the Rotem, and then you have what they are actually showing, what is the coagulopathy, and you have some treatment suggestions. If you look at the first part, that is to use either the TEC or the Rotem with a prolonged time to activation. This signifies that there's a lack of coagulation factors, and if you have a patient bleeding, then you can consider a dose of fresh frozen plasma to normalize this. Another level would be, for example, the fibrinogen level here seen either in the TEC or the Rotem. If this is decreased, then you lack fibrinogen, and then you can consider giving extra plasma, giving extra cryo or fibrinogen concentrate to normalize clotting if the patient bleeds. But another point is that if you actually have a normal TEC or normal Rotem in a patient bleeding, controllable bleeding or a bleeding that is not life-threatening or massive, then you can avoid using blood products. And that is extremely important, that the TEC and the Rotem actually gives us the opportunity to avoid extra transfusion. So if you have a normal TEC or normal Rotem, you do not lack plasma, you do not lack platelets in your transfusion strategy. Then you can avoid exposing patients to further plasma and platelets. So this is an important part of using the TEC and Rotem, that is to avoid unnecessary transfusions as well if you have a normal hemostatic profile. Of course, the viscoelastic hemostatic assays like the TEC and Rotem have limitations. One limitation is that they are not able to see the effect of platelet inhibitors like aspirin and clopidogrel. That is because they bypass the effect of these drugs. So we need other assays to show if there's a coagulopathy related to platelet inhibitors. Another another limitation of the TEC and Rotem is the inability to see the aggregation of the platelets towards endothelia. So the interaction with endothelia is not seen in the TEC and the Rotem. And that is important in patients with von Willebrand's disease or in patients with severe uremia, where you can actually see a deficiency in this part of hemostasis, that is the interaction between the endothelia and the platelets. But in general populations, in more than 99% of patients, this is not a problem. So if you exclude platelet inhibitors like aspirin and clopidogrel, and you exclude patients with uremia and von Willebrand's disease, you actually see most of coagulopathy in the TEC and Rotems. But you should, of course, be aware of the limitations. So our concept in Copenhagen is to be very liberal in massive bleeding patients and then shift towards a strategy where you work with a TEC, or you could work with a Rotem, but we work with the TEC to adjust your therapy accordingly. We work with it in a way that we decided to have bioengineers skilled in working with this analysis, initiating analysis. So we actually have the analysis, the TEC, in the blood bank, being able to perform these in a very standardized, controlled environment by technicians skilled in these types of analysis. Some centers work with them bedside, but we have chosen to work with them in this very controlled environment, very close to the operating room or the ED, giving us the ability for as clinicians to work with the patient, and then the blood bank makes the analysis, and then we can work together on the solution on the patient. So the blood sampling is done in the clinical environment, the blood bank is performing the analysis, the TEC analysis, and then we can monitor the results of the TEC in the OR, for example, as seen on the left here. You can follow the hemostatic buildup during the phase of the treatment of a patient with bleeding. Furthermore, we have a 24/7 on-call specialist team that is available to guide and interpret the TEC results and be a part of the team to assist the clinicians in treatment of these bleeding patients So our concept is to collab closely, and we believe by having this close collaboration between the blood bank and the clinical environment, we have a turnover time of approximately 15, maybe 20 minutes from doing a sample, setting up an analysis, getting results. So already within 15 minutes we can actually adjust the therapy according to the tech and give a better treatment for the patient on an individual basis. There are several causes of coagulopathy. Most of the causes are seen in the tech or in the rotem, and the problem with the coagulopathy is that they actually induce this microvascular bleeding. So you actually see an oozing, a microvascular bleeding, and as I said in the beginning, this is correlated with a poor outcome. So coagulopathy have several causes that is related to dilution, that is related to acidosis, hypothermia, and reperfusion injury. It can also be related to antithrombotics. But all these factors can induce the coagulopathy, cause the microvascular bleeding, cause that there's no clotting at the surgical site, making it very difficult for the surgeons to get control of bleeding. One of the things, as seen at the top, is the coagulopathy related to trauma shock, acute traumatic coagulopathy. That has been discussed a lot during the last 10 years. In Copenhagen, we believe that the endothelia, the vascular endothelia, is important to understand this traumatic coagulopathy. The vascular endothelia is the surface of all vessels in the blood, all vessels in the body, that is the venous and the arterial side. All these are with the surface of endothelia, and especially the glycocalyx, as seen on the photos here, a very delicate surface layer that is trying to avoid clotting to activate by itself, but trying to make sure that the bloodstream in the lumen just passes through without activation. So this endothelia is approximately 1 kilo or 1 liter of plasma in balance on the surface of all vessels in the body, and this endothelia is very much in balance with what is going on. In different type of diseases, you can actually see that there is a damage to this endothelia. For many years we have been looking at trauma patients, looking at different types of tech traces, showing us that there is a correlation between the tech trace and the coagulopathy developed. This model is just to show you the interaction with the endothelia. You see the endothelia on the bottom, you see the normal endothelia on the left, and you see a very damaged endothelia without any endothelial cells on the right. What we know now is that depending on the size of the catecholamines, depending on the size of the trauma, you will have an effect of the catecholamines damaging the endothelia. So if you have severe or massive trauma, you have a very high level of catecholamines damaging the endothelia, dissolving the endothelia and dissolving the glycocalyx, that was the surface, and all this will actually then go into the bloodstream, into the lumen, and cause the coagulopathy. So we believe that the drivers are the coagulopathy, the drivers of the coagulopathy is the catecholamines, depending on the size of the trauma. So high levels of catecholamines is devastating for the endothelia, causing downstream coagulopathy in the bloodstream of the patient. And so coagulopathy in our mind in Copenhagen is related to this very close collaboration or effect on the endothelia. We believe that this sympathico-adrenaline activation is what that actually drives the damage to the endothelial dysfunction, and thereby secondary causes the coagulopathy. So you have a coagulopathy related to the activation of sympathico-adrenalines like adrenaline, noradrenaline, and such, and related to the hemorrhage, related to the shock. This is just a devastating circle of worsening coagulopathy because the endothelium will be damaged. The sympathico-adrenaline activation will induce further coagulopathy, will induce more bleeding, more shock, and so on. So this is actually a lethal triad that actually can be caused by this endothelial damage. A lethal triad more than the lethal triad of acidosis, hypothermia and coagulopathy. So we need to stop this, and this can only be stopped by stopping the injury, resuscitating the patient, but being very aggressively in normalizing coagulopathy during the phase of bleeding. Some of the correctable causes of coagulopathy is well known. In patients that is hypovolemic, hyper-resuscitated, you have this developing lactate acidosis that can be seen in the pH or the lactate or the base excess of patients. And this is related to hyperperfusion, and this is related to patients that is hypovolemic. So this is one of the things that causes coagulopathy, and we should try to avoid this. And the only way to avoid this is to stop the bleeding and resuscitating the patient back to a normal volemic state. If the patient then is normal volemic, has stopped bleeding, they will then, from a renal point of view, decrease the acidosis and normalize the pH. Another correctable cause of coagulopathy is the hypothermia. The hypothermia is extremely important because when you have a hypothermic condition, that is a temperature below 35 degrees Celsius, then you have a lot of enzyme systems in the body that is actually have a decreased function. So the activity is decreased in the coagulation cascade, but also in other systems in the body. One other good example that is the circulatory system, the cardiac output is actually decreased equally if you are in a hypothermic condition. If you have a temperature of approximately 33 degrees, you have a more or less 50% reduction in cardiac output, and that is extremely important. So remember hypothermia, avoid hypothermia in order to avoid coagulopathy related to this, but also in order to avoid other systems by decreasing their activity, as said the circulatory system as well. So we need to be very aggressive in avoiding coagulopathy related to hypothermia, that is keeping the patients warm, only using heated fluids, blood products, giving them in a rapid infusion system or in a blood warmer to make sure that they do not get hypothermic, to induce the temperature in the operating room or in the emergency department or in the ward, making sure that the patient is treated to avoid hypothermia. This is extremely important. Another correctable cause of coagulopathy is the hypocalcemic state. In plasma you have a lot of citrate, and this is when the citrate enters the body, you will have a recalcification of the citrate, making calcium disappear from the bloodstream, and that is just to avoid the effect of the citrate. The citrate is actually a little bit of anticoagulation. So in a patient receiving plasma, especially plasma, there's a little bit of citrate in RBCs and plasma platelets as well, but especially in plasma resuscitation, you will see a decrease in calcium related to the use in order to remove the effect of the citrate. So calcium should be used very aggressively in bleeding patients. You should monitor it closely by arterial blood gases to see if there's a sign of it decreasing. If it's decreasing, you should treat it when you're in a phase of bleeding. And you should expect, when you use plasma, to give a lot of calcium. I have a rule of thumb saying 5 for 5. That is, if you give 5 plasma products, you should substitute 5 millimoles of calcium on top of this, and then further monitor to see if this is enough. So calcium is important to avoid the coagulopathy related to the calcium going low, related to the plasma resuscitation. So monitor and treat it aggressively, for example, after the rules of thumb, 5 millimoles of calcium for 5 plasma products. In managing bleeding patients, you should be aware that it's only a minor population of patients having massive bleeding. That is approximately between 1 and 2% of most patients. Most patients do have a controllable bleeding, and patients challenged by a controllable bleeding you should be very restrictive with the use of blood products. You should remember that blood products are from donors. They're actually cells and protein from other humans that is actually transplanted into the patient. So if you are in a condition with controllable bleeding, you should be very restrictive as compared to the massive bleeding, where you are generally liberal with the use of blood products. Dividing these two patients is extremely important to be aware that you, in massive bleeding, should be very liberal with use of blood products, but as soon as you get control of bleeding, you should shift the strategy towards a much more restrictive use of blood products, and that goes for RBCs, plasma and platelets. One of the reasons for this is, of course, the transfusion complications. One of the most important parts is human errors, that the most frequent type of transfusion complications. Other types of complications are the allergic reactions, the transfusion-associated cardiac overload, that is just giving too much blood to a patient, so you get a cardiac overload situation. And then you have the transfusion-related acute lung injury, that is immunological reaction in between the donor leukocytes, white blood cells, and some antibodies in the patient, or the other way around. So you actually have an immunological reaction from the antibodies of the donor towards the leukocytes in the lungs of the patient. So this is a lung injury situation where you have a very severe reduction in oxygenation. These types of patients require mechanical ventilation, require a lot of oxygen to manage this. And this is a immunological situation, trially, that is very rare. It actually occurs in Denmark in between 2 and 3 times a year in Denmark. It's the same number in Sweden and Holland as well. So it's a very rare complication to transfusions, but it's there, and it carries a very high mortality. So again, remembering that if you are in a situation with controllable bleeding, you should be very restrictive with the use of blood, and that is primarily to avoid the complications of blood transfusions. But as a concept, you can see our Copenhagen concept here. This is seen from different aspects. If you go to the lower part of the figure, you can see that you have time. You have start of hemorrhage, time 0, and you have time after 30 minutes, 60 minutes, and time for surgical control, that is hemostasis, seen here. So you have actually aspects from start of bleeding to control of bleeding. You can divide patients to the phase where if in trauma, for example, you have early phase of uncontrollable hemorrhage. This is seen in the bottom. You can look at that from the aspect of a patient arriving, and that within 5 minutes you can evaluate that patient, and you can see that this patient actually has, as seen on the blue line, you have a situation with uncontrollable hemorrhage. Then you initiate therapy with a ratio 1:1:1 strategy, that is transfusion packs, giving them RBCs, plasma and platelets, but at the same time running the TEC or the ROTEM in order to understand what is going on in the hemostasis. Furthermore, you work with all the adjuncts of treating bleeding patients, that is to make sure that you correct temperature, calcium, you avoid acidosis, and you are very much aware of treating the acidosis by resuscitating the patients. On the upper part as well, you can see that antifibrinolytics has a place in the treatment of these patients. You have the CRASH-2 trials, CRASH-2 trial, that is use of tranexamic acid, the antifibrinolytic in trauma patients, 20,000 patients randomized to either receiving 1 gram of tranexamic acid as early as possible, and then 1 gram in 8 hours, as compared to patients receiving placebo. And this study actually showed improved survival in patients after trauma. So tranexamic acid in trauma has a part in the treatment, and we work with it from the early phase. But you should remember, in most other types of bleeding patients, surgery, major surgery, we have, as I recall, it's a little bit above 270,000 patients randomized to either tranexamic acid or placebo, showing us that you can reduce the need of blood products and reduce bleeding by using tranexamic acid in most types of surgery. So surgery and trauma, tranexamic is in there and should be used very liberally to avoid bleeding, to avoid transfusion requirements in our patients when they have bleeding. So this is as one of the strings of the treatment. But as you can see by the blue, you have the initiation of therapy at 5 minutes from arrival, when you have a situation that has changed after approximately 30 or 40 minutes of treatment. You have a situation where you now are more or less in control of hemorrhage. You can then shift from giving blood products in packs in a ratio 1-on-1 guided fashion towards a goal-directed TEC and ROTEM guided resuscitation. VHA, that was viscoelastic hemostatic assays, that is the TEC and ROTEM guided assays. So you shift from doing ratio 1-on-1 strategies towards doing TEC ROTEM guided goal-directed therapy, only giving the patient what they're actually needing. So if they are lacking plasma, give them some plasma. If they are lacking platelets, give them some platelets. But if they have a normal TEC or ROTEM, they do not need plasma and platelets, and then you can avoid the exposure to these products. When you get surgical control of bleeding, you stop transfusions, you stop monitoring, and you remember that this patient is now changing from a bleeding phase to a phase where thrombosis is the main problem. And therefore it's extremely important when the surgeons have controlled bleeding or the patient has stopped bleeding, then you stop transfusion, you just do the standards, maybe monitor the hemoglobin, and then you change towards a phase where you're much more evaluating thrombosis than bleeding. My key points in the treatment of bleeding patients is that you need to remember the most important part of treating patients' bleeding is to stop the bleeding, that is in controllable bleeding or in massive bleeding, stop the bleeding and then be very, very restrictive in use of blood products. If you have a patient with massive bleeding, be very early and aggressive in the use of blood products. Aim for a ratio 1-on-1 of RBCs, plasma and platelets to make sure that you're actually delivering what the patient is losing. Whole blood is lost and you deliver something that is equal to whole blood. Run the TEC and ROTEM at the same time to monitor the clot, and then adjust the ratio concept according to the TEC and ROTEM. When you get more control of the bleeding, then you only give what the patient is actually needing. And this should be a goal-directed approach. So this was the close of my talk. Thank you for listening.